Thank you, Sanjay, for inviting me. It's a very interesting topic as far as the Indian subcontinent is concerned. But as I was just discussing with one of the audience doctors, there are these issues that come up in US as well. So let's talk a little bit about portal biliopathy, and we have experts also amongst the audience who can give their comments. So how do you define portal biliopathy? This is basically abnormalities in the biliary system, predominantly in the extrahepatic bit, but with or without intrahepatic abnormalities, which results from extrahepatic portal venous obstruction, leading on to a portal cavernoma. This portal cavernoma causing CBD obstruction was first known in 1944, then in 1965, again in 1965 by Hunt. But what drew our attention when we first described this entity in 1992 was an article written by one of our friends, Dr. Gaur Chaudhary from Lucknow, who made a case report on a biliary obstruction in a patient with extrahepatic portal vein obstruction, which after surgical decompression of the portal hypertension became absolutely normal. So this is what drove us towards this, thing which is portal biliopathy. And you diagnose this by way of imaging. There has to be a portal cavernoma, characteristic cholangiographic alterations on MRCP or ERCP. We didn't have MRCP that time, and this I'm talking of 1989 onwards. ERCP used to be the only modality available with us. And after you have excluded the other conditions like primary sclerosing cholangitis, cholangiocarcinoma, biliary ascariasis, etc. So this has been variously named as portal cavernoma cholangiopathy. This was in 2014 because there were a number of studies that had come out after 1991, 92, all with different names. Like when we came out with our publication, we call it as pseudosclerosing cholangitis because there was no name given to it. Then similarly, Professor Kuru, he came out with another terminology, pseudocholangiocarcinoma, portal ductopathy by a Turkish hepatologist, portal cholangiopathy, portal hypertensive biliopathy. So there was no consensus, and we felt the Indian National Association for Study of Liver said that portal cavernoma cholangiopathy is the right word that should be adopted. But I have carried on with portal biliopathy since the topic was on this particular heading. So this is common in extrahepatic portal vein obstruction, but has also been described in cirrhosis and NCPF. But this is usually the extrahepatic portal vein obstruction leading to biliary changes in the extrahepatic bit of CBD has been described, but not extensively. And intrahepatic changes have been described because of the nodularity present in cirrhosis and non-cirrhotic portal fibrosis. Series were published from 1990 onwards with very limited number of patients. We published a series of 20 patients. Dr. Kuru published a series of 22 patients or 24. Serene published all during that time. So, and some more studies have been published later on, as recent as last year, with a number reaching almost 60 to 100. So there have been, the number of patients have been very limited. And the limitations of all these studies is that they have all been retrospective. Prospective studies have been lacking, and very little studies on cirrhosis and portal biliopathy. So before coming to the condition as such, let me just take you through the bile duct vascular anatomy. It is supplied by the branches of the celiac trunk, especially the posterior superior pancreaticoduodenal, and some branches of the right, left, hepatic, and cystic, which perforate the bile duct wall, leading to intramural and subepithelial plexus. It is worth noting that the supraduodenal portion of the bile duct is least vascularized, and this is prone to develop ischemia. The venous plexus of the common bile duct characteristically has two types of plexus. One is the epicholedochal plexus of Saint, which was described many years ago, many decades ago. And this is the fine reticular vascular pattern which is seen in the wall of the common bile duct. But vessels or collaterals or plexus running parallel to the common bile duct, known as the paracholedochal plexus of Petrin, is the one that leads to abnormalities in the common bile duct. And these plexus ultimately drain to the gastric, gastrocolic, posterior superior pancreaticoduodenal veins. Some perforators have also been described by way of endoscopic ultrasonography from extramural to the intramural veins. And whenever portal vein gets blocked or thrombosed, jump collaterals try to skip the site of obstruction from the area distal to the portal vein to the proximal portal vein so that the blood supply to the liver is maintained. Ultimately, these jump collaterals lead to what is termed as a portal cavernoma, which at times becomes solid tumor-like, and this encircles the bile ducts. So whenever a block occurs in the splenopotomecentric venous system, which more often is observed in children as compared to adults, these blood vessels tend to dilate. And the collaterals around the common bile duct, as I mentioned about the pericholedochal plexus, they distend on a very floppy common bile duct, and they produce indentations, scalloping, filling defects, all of which are reversible whenever a shunt is done. But then at the same time, after you have done shunt, because of thrombosis of the small venules and arterioles supplying the bile duct, there is also local ischemia, which leads to short segment fibrotic strictures, wall thickening, and ultimately portal cavernoma. So there are two important components which bring about biliary changes in patients with extrahepatic portal vein obstruction: the compression, which is reversible, and ischemia, which is not reversible. And infection also keeps on happening because of the portal biliary abnormalities, which leads to subclinical cholangitis, inflammation, neogenesis, fibrous tissue deposition. So it's a combination of all these. And one sees these extrahepatic biliary abnormalities and intrahepatic. At least in our series, we found almost 100% of our patients had these abnormalities, with more abnormalities in the left hepatic duct compared to the right hepatic duct. After having read Dr. Chaudhary's article, we used to get a very sizable number of patients with extrahepatic obstruction, children who presented with bleed, and some of them with minor pain abdomens, even without any evidence of cholangiopathy or evidence of obstructive jaundice. We did ERCPs in a few patients, and to our surprise, that almost 100% of them had biliary abnormalities. So this was something very new that we had not known. And almost in the 20 patients that we published in Gut that time, all of them had evidence of these biliary abnormalities. And this is normally you expect the bile duct on an ERCP to be straight borders, but it had indentations which were possibly due to the paracholedochal vessels which had dilated. So having read other reports coming from centers like Dr. Kuru's from Sher-e Kashmir and Dr. Sareen's from Delhi, so we were confident that we are in the right direction. And everybody gave their inputs for this particular condition. But when you look at the natural history of portal biliopathy, there is not much study. As I said, they're all retrospective, very few prospective. Most of the people believe that it has a very slow progression, but others also believe that it does not progress, as has been evidenced in one of the studies from the West, which shows that over a period of 4 years, the portal cavernoma and biliopathy, which was existing in 45 patients, it was non-progressive. So this was, we believed, a disease of the young with minimum age of 6 years, and most of these patients were asymptomatic. Possibly even younger would have been affected, but since ultrasound was not very popular that time and we didn't have imaging of CT scan or MRI, we were not very clear doing ERCP in all these patients. So hence, whatever reports are available, the youngest reported is 6 years, but I'm sure there must be many more with even lesser years, provided they have extrahepatic portal venous obstruction. One of the recent studies from PGI showed in children less than 13 years on MRI that 53 patients of portal biliopathy, all of them were asymptomatic, with extra and intrahepatic ducts being abnormal in 85% and severe abnormalities in 58% of these patients. And they found that it was present more often in patients who had portal vein, splenic vein, and superior mesenteric vein block. There was another study which also showed that the bigger the angulation of common bile duct, increased were the chances of strictures and formation of stones. And portal biliopathy can occur within a year after having developed portal vein thrombosis. But then you have another group which is symptomatic, which was seen in about 5 to 38% of cases as more and more centers took up seeing these types of patients. And prognosis in symptomatic patients is poor unless you give an effective treatment. They become symptomatic once the strictures become fibrotic. And because of these strictures, stones tend to develop in the common bile duct as well as in the intrahepatic portion of the bile duct. So studies have shown that older the patient, longer duration of extrahepatic obstruction. After the first bleed, that was the symptom that they came to the patient, to the doctors. It was about 8 to 14 years. And these patients had dilated segments of the bile ducts and stones. They presented with recurrent jaundice in about 50% of cases. Some of them had abdominal pain, and about 1/4 of them had evidence of cholangitis. And on investigations, almost 35% of these patients had gallstones. And these were possibly related to biliary stasis, increased lithogenicity, hemolysis, and hypersplenism. But almost 40% of these patients also had choledocholithiasis. And this was all because of these strictures that these patients had. It was more in symptomatic than in asymptomatic and was independent of gallstones. So as I said, longer the stricture, multifocal strictures, and the chances of choledochal and intrahepatic calculi were more. We also found that these extrahepatic obstruction patients had gallbladder varices, like ectopic varices. They tend to happen more often in extrahepatic portal vein obstruction. We found it in about 34% of cases as compared to only 13% in patients with cirrhosis. Yet a recent study from Bombay in 97 symptomatic portal biliopathy patients showed that more than 50% of them did not have shuntable veins, and they presented to them 12 years after the index bleed. So these patients who were symptomatic had to have repeated ERCP interventions. Very rarely these patients go on to develop end-stage liver disease. If there is extensive venous thrombosis, you cannot do a shunt procedure in them. There is progressive liver dysfunction, recurrent cholangitis, and ultimately they develop secondary biliary cirrhosis. which would require a liver transplantation. In our own experience, the huge number of patients that we have seen, I think just 1 or 2 out of more than 100 that we have seen in PGI required a liver transplantation. So when you investigate these patients in the asymptomatic phase, the liver functions are normal, except occasionally a mild rise in alkaline phosphatase and GGTP. Ultrasound and Doppler is the investigation of choice in these patients. It is a screening modality, and you would see atretic or recanalized portal vein, but essentially you see a portal cavernoma, which is mass-like and has a lot of serpiginous collaterals, which leads to biliary dilatation. You would see gallbladder varices in them, gallstones, and even choledocholithesis. But you need to do further imaging in case the patient has hyperbilirubinemia, because then you have to tackle these patients as well. And the gold standard for diagnosing biliopathy is MRI with portography, MRCP with portography, which tells you both the vascular and the biliary anatomy in a non-invasive way. So the common bile duct is undulating, narrowed, as nodular extrinsic defects, and MRCP differentiates stones from varices because they both look like filling defects. Essentially, it gives you a roadmap for any further biliary or vascular intervention at a later date. So these are the MRCP findings, which shows grossly abnormal common bile duct and intrahepatic biliary tree. And here again is an axial section, which again shows a non-smooth bile duct abnormalities within the liver and outside. The CT scan was earlier used, no more the gold standard, because you may have to do repeatedly the assessment of the biliary dilatation and see the CBD changes. And since it gives you radiation exposure, MRCP is the preferred choice. It tells you about the extent of thrombosis and collaterals. And one of the authors has described a pancreatic head enlargement even in these patients, giving a picture of pseudomass because of the peripancreatic collaterals. ERCP is no more done for diagnostic purposes since it is invasive, and only if you have to do a therapeutic procedure should it be done. And these are the ERCP findings in patients who has a portal biliopathy with a stone, which was successfully removed after doing a sphincterotomy. Recently, endoscopic ultrasound has also been taken up as one of the modalities for diagnosing portal biliopathy. Although whenever there is a confusion between common bile duct stone or a bile duct varices, EUS is better than MRCP. And it also tells you about the perforators. So it is helpful in doing biliary endotherapy at a later date. Just an example of one of the patients that was recently done at PGI. Courtesy, I got these films from one of the faculty members there. So since a lot of authors described portal biliopathy, they classified it according to the location, severity, and the type. And location, they said, this is from Dr. Sareen's group, type 1 if it is extrahepatic involvement mainly, type 2 intrahepatic bile ducts involvement, type 3A is extrahepatic and unilateral intrahepatic bile duct involvement, and type 3B extrahepatic with bilateral intrahepatic bile duct. So most commonly you see type 1 and type 3. Then severity you assess by way of grade 1 if there are irregularities and angulations of the biliary tree. Grade 2 is strictures without dilatation. Grade 3 is strictures with dilatations. And depending on the length of the stricture, you could grade the severity. And types have been described by the Japanese group. It could be a varicoid, fibrotic, or a mixed variety. So once you have these abnormalities and you're very not clear whether the patient has extrahepatic obstruction, you have to rule out primary sclerosing cholangitis, cholangiocarcinoma, HIV cholangiopathy, biliary ascariasis, IgG4 cholangiopathy, and pericholedochal lymph node, compressing the bile duct. But once the ultrasound characteristically picks up the cavernoma, then you're very sure that 99% of the cases you are dealing with portal biliopathy. A study from Delhi, where they studied the portal cavernoma in 50 patients with portal biliopathy, showed that it had multiple dilated portal venous channels, hepatic artery thickening, elastosis of the portal vein, aberrant vascular channels around the portal tract, and bile ductular reaction. And one more study showed that extreme wall thickening in cavernoma is characteristically seen in portal biliopathy. So how do you manage these patients? If they are asymptomatic, liver functions being normal, one should leave them alone. Although there is a group which says that even with mild rise in alkaline phosphatase and GGTP, without a rise in bilirubin, one could prevent portal biliopathy, but there is not enough evidence to support that. So intervention is required only if the patient is symptomatic. It's a dilemma for physicians and surgeons, and you need to have a stepwise approach from a less to more invasive procedures. Like you start with endoscopic procedure, you may go with a radiological complement or a surgical complement. But since the experience is limited, it has to be a multidisciplinary approach. But the most common intervention is the biliary interventions, which is done by ERCP. It is indicated if there is cholestasis, choledocholithiasis, cholangitis, cholangiola, abscess, and stricture formation. And you could do a sphincterotomy or a balloon sphincteroplasty, which are relatively safe, but there is always a risk of bleed, which is very rare since the bile duct is congested and you expect some collaterals in the region of the ampulla where you do the sphincterotomy. So hemobilia may occur. It is usually mild, settles conservatively. Occasionally, you may require injection terlipressin, as has been reported in some case reports. And there is a case report that if you induce hypotension, possibility of a bleed may stop. Usually when you do a balloon sweeping or a domia basket and you're not very careful, you tighten the basket, it is possible that a choledochal varix may come into it and lead to hemobilia. So one has to be very careful, come out with an open domia basket or preferably do balloon sweeping. And because intracholedochal varices, they mimic stones. So there should always be a surgical backup whenever you are doing an intervention. In the earlier days, when we were not very familiar with stent exchanges, we used to do nasobiliary drainage for patients who had come with cholangitis to us. But then with good stents being available, it came into vogue that plastic stents should be used in case these patients have cholangitis. But very often relapses tend to occur because these plastic stents do not remain patent for long. Their lumen gets blocked by a little amount of bile, microliths, and blood, and hence you have to repeatedly change the plastic stents. One of the largest series, again from SGPGI Lucknow, by Dr. Vivek Saraswat, 20 symptomatic portobiliopathy patients with obstructive jaundice had 130 ERCP procedures doing balloon dilatation and plastic stent exchanges every 3 to 4 months till the liver function became normal. But they also had complications like hemobilia, recurrent cholangitis, and compliance is a problem because if there is no shuntable vein, the patient keeps on coming to you. So compliance becomes an issue with such patients. And this group also could relieve the strictures with the help of either balloon dilatation or prolonged putting prolonged bundles of plastic stents. Then came the era of non-covered metallic stent, which was initially used, but whenever it was to be removed, it led to a lot of bleeding. And this was because of intimal hyperplasia. So now with the availability of self-expanding, fully covered metallic removable stents, this is now the practice in some of the centers. Whenever there is a CBD stricture which is not responding to repeated plastic stents, or if the patient develops hemophilia, and to control that, it is one of the rescue therapies. To be noted is that cholecystitis may occur in about 48 hours because you're tending to block the cystic duct as well. But most of these patients become well after a short while. None of them requires surgery. This is from a study which included about 11 cases of self-expanding covered stents. And these patients remained asymptomatic, average 3 years, but maximum up to 10 years. Another study of 114 patients, the biliary symptoms improved in 30% with a single endoscopic intervention. 43% had multiple plastic exchanges. Small proportion metallic stents were given, and almost 30% of them had surgical treatment in the form of shunt, TIPS, and liver transplantation in minuscule number of patients was given. For larger stones, laser and mechanical lithotripsy can also be done. And another study from Bombay, in 35 portal biliopathy patients, 363 endoscopic sessions were done, 3 to 29 procedures, hemophilia 6%, and frequent stent exchanges because of cholangitis occurred in 28% of cases, and 11% of them had secondary biliary cirrhosis. There are 1 or 2 case reports of cholangioscopy also being used for removing the biliary casts and assessing the common bile duct. Recently, intervention radiologists have come to the help of such patients. Earlier on, PTBD was done, the percutaneous biliary drainage, if there was cholangitis, and the patient was unstable with hemodynamic and altered mentation. But TIPS has now been shown to be of use in patients with extrahepatic portal vein obstruction. And if you can, it is technically challenging, but if you select these cases properly, expert radiologists have achieved stenting in 87 to 100% of these patients with a primary patency of 73%, as seen in cirrhotics. But when it is done in patients with extrahepatic portal vein obstruction, there is restenosis in 70 to 90% of cases. So there is a rapid recurrence of the block of the shunt. It just gives you a little time for decompressing the portal system, and you should do a decompression of the biliary system simultaneously. So TIPS is done through the transjugular route, transhepatic, transplenic, transmesenteric, or collateral vein stenting, depending on the expertise of the radiologists. And I came across this study of only 6 cases where TIPS was done in portal biliopathy without any complications. And they could do a PTBD after the TIPS was done and relieve the patient of the biliopathy symptoms. But surgery is something which is definitive and highly complex and risky. You decompress the portal system with the help of shunts, preferably non-selective shunts, and portal biliopathy disappears in 60 to 80% of patients within 2 weeks. But certainly, as I mentioned, there is a group which doesn't get relieved with shunt surgery. So you need to do second stage biliary decompressive procedures like hepatocojejanostomy and choledochoduodenostomy. As I said, that most of these patients have a block of the portal, splenic, and mesenteric vein. So you have very little option for doing any shunt procedure. But experts have been able to do between collaterals and vena cava, mesorenal shunt, and Rex shunt, which is the procedure of choice for the treating of extrahepatic portal vein obstruction, usually is very difficult because there are a lot of collaterals in the left branch of the portal vein, and it's a very bleeding associated procedure. So for non-shuntable veins, you have either esophagogastric devascularization with splenectomy, which is rarely done, but it helps in lowering the portal pressure, or you do a bilioenteric drainage by way of hepatococcegestomy. And one series from Delhi reported 18 patients with a follow-up of 11 months to 12 years, and with only one operative mortality and recurrence in 2 patients. So biliary surgery, you can do the Roux-en-Y anastomosis, but these are all very small group of patients that have been reported in the literature. And there are also reports that the fear of laparoscopic cholecystectomy, that these patients would bleed because of gastric varices, is true, but is very successful in good surgical hands in selected groups where the patient has had prior portal vein decompression. Liver transplantation is reported in very small number of patients whenever there is non-shuntable vein, ineffective biliary drainage, progressive liver damage, recurrent cholangitis, and repeated stents do not help the patient, and the patient has gone into secondary biliary cirrhosis. And it's usually recommended that the deceased donor liver transplantation should be done, because the amount of portal vein that is available in the recipient is hardly there. So it's a complex surgery. Not very many reports are there in the literature, but can be an option in expert hands. So friends, in conclusion, I would say that portal biliopathy is always present in extrahepatic portal vein obstruction. Usually it is asymptomatic, doesn't require any treatment, and symptomatic patients have a long-term poor prognosis because they tend to have cholangitis and common bile duct stones. Management is by endoscopic stents, either plastic or the fully covered metallic stents. Ideally, you should try a decompressive shunt surgery and followed by bilioenteric drainage. But we need to explore how tips can help us, or possibly think more of liver transplantation. So thank you all for a patient listening, and I'm open to questions. Thank you, Sanjay.
Thank you.